Cardiogenic shock is best understood as a syndrome of inadequate cardiac output leading to end-organ hypoperfusion. The key modern shift is that we're no longer thinking about classic post-MI patient with profound hypotension. Today, we increasingly recognize heart failure-related shock, mixed phenotypes, and progressive multi-organ hypoperfusion that may appear before the blood pressure fully collapses. This is why contemporary management has moved beyond isolated bedside decisions. The newer model emphasizes early recognition, rapid hemodynamic profiling, repeated reassessment, and structured shock team activation. In other words, the field is shifting from reactive rescue towards organized, physiology-driven care. Conceptual model of shock includes why a single label is not enough. Modern shock assessment rests on three axes. The first is severity, usually graded by the sky stages. The second is phenotype, meaning what kind of shock biology are we dealing with? Acute myocardial infarction, acute and chronic heart failure, isolated right ventricular failure, or a mixed picture. The third axis includes important modifiers such as age, systemic inflammation, and cardiac arrest. That matters because two patients may both be called cardiogenic shock, yet have very different trajectories and treatment needs. A patient with AMI shock and a patient with decompensated chronic heart failure may both be hypotensive, but the congestion burden, ventricular involvement, and response to support can be very different. This three-axis model helps us think more precisely and act earlier. The Sky classification involves a severity pyramid. The lower portion of the Sky pyramid helps us understand early shock. Stage A means the patient is still stable. Stage B means beginning of the shock. The patient has hemodynamic instability, such as hypotension, but has not yet declared frank hypoperfusion. Stage C is classic cardiogenic shock, where hypoperfusion is now evident and the patient usually requires pharmacological or mechanical support. Stage B is a major opportunity window. If we wait until a patient clearly reaches stage C, we are already behind. Recognizing shock before irreversible organ injury develops is one of the major goals of modern shock systems. The extremist threshold highlights the high-risk end of the spectrum. Stage D refers to deteriorating shock. The patient has already received initial therapy but is failing to stabilize. Lactate may be rising. Vasopressor requirements may be escalating, and end organ perfusion may still be worsening. Stage E or refractory shock includes severe acidosis or outright circulatory collapse. The practical lesson is that shock is dynamic, not static. A patient does not simply get a stage once and keep it all day. Serial reassessment is essential. If the trajectory is worsening despite initial support, that is the moment to escalate, broaden the differential, involve the multidisciplinary shock team without delay. The golden 24 hours. The first 24 hours often determine whether a patient stabilizes or spirals. There are three specially useful markers: cardiac power output, PAPI, and lactate clearance. Cardiac power output combines mean arterial pressure and cardiac output into a single measure of hydraulic performance. A value above 0.6 watts is generally reassuring, whereas low values suggest inadequate perfusion power and a high-risk state. PAPI gives us a focused window into right ventricular performance. A low PAPI should immediately raise concern for occult right-sided failure, which may be missed if we focus only on left ventricular shock. And lactate clearance tells us whether oxygen delivery is finally meeting tissue demands When lactate normalizes early, outcomes are better. So the message here is simple. In the golden first day, follow objective physiology, not appearance alone. Pulmonary artery pulsatility index is calculated by subtracting pulmonary artery diastolic pressure from pulmonary artery systolic pressure and dividing by the central venous pressure. This is a hemodynamic marker of right ventricular health. It reflects right ventricular contractile pulsatile load and congestion levels in shock states. High-risk phenotypes are identified when the PAPI is less than or equal to 1.5. If it is less than 0.9, patient is in overt right-sided failure. This is a powerful prognostic indicator. Along with right atrial pressure, this is one of the most robust predictors of in-hospital mortality. Hemodynamic goals for escalating or weaning support. PAPI less than 0.9 is a threshold for RV failure, and more than 2 is a hemodynamic goal post-support. Cardiac power index, which we discussed earlier, less than 0.6 watts is a threshold for failure, and more than that is a hemodynamic goal post-support. Central venous pressure should be less than 8 post-support. The Doremi trial was an important shock trial because it directly compared milrinone with dobutamine in cardiogenic shock and found no significant difference in the primary outcome. In practical terms, that means neither drug proved clearly superior. Both remain reasonable inotropes, and the choice often depends on patient phenotype, blood pressure, renal function, pulmonary vascular load, and clinician familiarity. The more important point may be that the trial did not show inotropes do not reverse shock biology by themselves. They can buy time, improve forward flow, and serve as a bridge. But a patient with rising vasopressor requirements in the first day is telling us the underlying shock state is still uncontrolled. That should promote a broader re-evaluation rather than simple dose escalation. Transcatheter therapies are a major temporary support option. Intra-aortic balloon pump provides modest afterload reduction, but it does not generate robust forward flow. Impella gives active forward and more direct left ventricular unloading, but requires thoughtful patient selection and device expertise. VA ECMO delivers full cardiopulmonary support and can stabilize the most profound shock states, but it also increases left ventricular afterload and may worsen distension if unloading is not addressed. So device choice should be phenotype driven. We should ask, which ventricle is failing? Is respiratory failure part of the picture? Do we need flow, unloading, oxygenation, or all three? The right device is the one that matches the physiology in front of us, not the one that is merely available. The danger shock trial represents a major shift because it provided contemporary randomized data suggesting a survival benefit with impeller use in carefully selected STEMI-related cardiogenic shock. The study reported lower 180-day mortality compared with standard care, with a number needed to treat of about 8 patients. But the critical teaching point is patient selection. This was not a blanket endorsement for routine device placement in every shock patient. Patients with out-of-hospital cardiac arrest and major right ventricular failure were excluded, which means the results apply to a narrower phenotype. The broader lesson is that support strategies work best when matched to the right patient subset rather than applied indiscriminately. VA ECMO can be life-saving because it rapidly restores systemic perfusion and oxygenation in crashing patients. But the hemodynamic trade-off is that retrograde aortic flow increases left ventricular afterload. That can versus elevate distension, raising filling pressures, and aggravate pulmonary congestion unless an unloading strategy is added. This is why ECMO should not be thought of as a simple on or off rescue tool. The question is not just whether the patient needs ECMO, but also whether the left ventricle is being adequately decompressed. The neutral results of trials, such as ECLS shock, reinforce that routine ECMO alone is not a universal solution. ECMO is powerful, but must be paired with the right physiological goals and, in some patients, active LV venting. Now, to understand VA ECMO, the venous cannula takes blood from the right side through the ECMO machine and is given back to the arterial side. As this is given back to the arterial side, the afterload to the left ventricle increases. And if this is not borne in mind, this could lead to an LV and diastolic pressure rise, causing pulmonary congestion. A way of mitigating this is what we call ECMELA, where you put an impeller to unload the left ventricle and via ECMO. Or you could do a balloon pump or an atrial septostomy or consider surgical options. Not all cardiogenic shock is pure pump failure. Structural disease, especially severe mitral regurgitation, can markedly worsen power output and accelerate pulmonary edema, congestion, and hypoperfusion. That is why it is so important to look for overlap between valvular disease, structural shock, and the broader syndrome of cardiogenic shock. The clinical implication is that bedside echocardiography is indispensable. If severe mitral regurgitation is driving the physiology, escalating pressures alone will not solve the problem. In selected patients, transcatheter mitral repair may become an important rescue or stabilizing strategy. The larger message is that shock therapy must include diagnosis of reversible mechanical contributors, not just escalation of drugs and devices. The jaws of life metaphor is useful because it reminds us that complex rescue tools only work when a coordinated team uses them well. In cardiogenic shock, the mechanical rescue includes things like cath lab interventions, device placement, extracorporeal support. The medical rescue includes ICU care, pharmacology, respiratory management, multi-organ support. Neither side succeeds consistently in isolation. Shock teams work best when interventional cardiologists, intensivists, surgeons, and heart failure specialists communicate in real time around the same data. That cross-disciplinary communication matters because advanced devices can save lives, but they also carry substantial complication risk if deployed late, mismatched to the phenotype, or managed in silos. Regional systems of care are essential because many hospitals can recognize shock, but not all can deliver advanced shock therapy. In a hub-and-spoke model, spoke hospitals identify the patient early, stabilize them, activate the transfer pathways quickly. Hub centers then manage higher acuity stages, advanced mechanical support, and durable heart failure therapies when needed. The key system lesson is early recognition. If peripheral hospitals wait until a patient is already in extremis, transfer becomes much harder and outcomes worsen. A standardized approach, including common language transfer protocols and rapid one-call activation, helps patients reach the right level of care while the physiology is still recovering. Finally, the modern approach involves a three-step profile: support and team. First, profile the patient early. That means defining the shock phenotype, the SKY stage, ventricular involvement, congestion burden, markers of end organ injury including hemodynamics, lactate, and bedside imaging. Second, support the physiology using targeted drugs and mechanical circulatory support based on what is actually failing. Third, involve the multidisciplinary team early when the patient is deteriorating or transfer is required. So the contemporary paradigm is not one miracle device or one preferred drug. It is a structured process. Identify the physiology early, match the intervention to the phenotype, organize the care through a coordinated team. That is how we improve odds in a syndrome that remains one of the most lethal emergencies in cardiovascular medicine. Thank you for watching. More to follow.